So as a way of background, the TRANSCEND-NHL-001 MCL cohort investigated Lisocabtagene maraleucel in patients with relapsed refractory mantle cell lymphoma. The primary analysis showed that Lisocabtagene yielded a durable complete remission rate of 73% in a very heavily pretreated population. In addition to which, the safety analyses were showing extremely manageable toxicities, particularly notable for low-grade CRS as well as ICANS. Grade 3 or higher CRS or cytokine release was seen in only 1%. Grade 3 or higher neurological toxicity was only seen in 9% of patients with relapsed refractory mantle cell lymphoma. At EHA, we, on behalf of all the investigators as the study team, are going to present a post-hoc subgroup analysis of the TRANSCEND-NHL-001 MCL cohort, basically focusing on two things. Number one, patients' response to prior lines of treatment, or based on prior lines of treatment, and number two, it would be based on refractoriness or relapse to a prior BTK inhibitor. So by way of study design, patients with mantle cell lymphoma, provided they had relapsed mantle cell and had been exposed to 2 or more lines of treatment, including a BTK inhibitor, an alkylator agent, and a CD20 antibody, age 18 and over. These patients were enrolled prior autotransplant, prior allotransplant, prior or active CSF involvement, CNS involvement were all permissible on this trial. A total of 104 patients were screened, of which 88 patients received Lisocabtagene maraleucel. 6 received at DL1, which is the dose level 1 at 50 million CAR T cells, the remainder at dose level 2 at 100 million CAR T cells. The primary endpoint of this study was overall response rate and safety. So with now the post-hoc subgroup analyses, the subgroups were divided based on prior lines of treatment into patients who had 2 lines of treatment, 3 to 4 lines of treatment, or 5 to 11 lines of treatment. And the net is that with regards to efficacy, it was comparable, albeit in patients who had prior lines of treatment that were 5 or over, the complete response rate was about 10% less. So for the entire cohort, the complete response rate was 73%, but for patients who had 5 or more lines of prior treatments, their complete response rate was 65%. Now focusing on the second subgroup analysis, which was based on response to a BTK inhibitor. Majority of BTK was second-generation BTK inhibitors. Patients also were treated with first-generation BTK inhibitors, a handful of patients with pirtobrutinib as well, which is the reversible BTK inhibitor. But with regards to responses, they were divided into relapsed or refractory. So majority of patients were refractory to BTK inhibitors. And again, if we look at the entire cohort, the complete response rate was 73%. But if they were refractory to a BTK inhibitor, their response rates dropped to a complete remission rate of 65%. It's also important to note that these were the patients who were also heavily pretreated, majority of which had received 5 or more lines of treatment. With regards to survival analyses, the median duration of response, the median PFS for the entire cohort was about 15 months. The median overall survival was 18 months. But when we look at these subgroups for patients who had 5 or more lines of treatment, the median PFS was lower at 6 months, the median duration of response was lower, and the median overall survival was less than 18 months, which was for the entire cohort. When you look at refractoriness to BTK inhibitor, we can tell that it was again comparable, but the median PFS was again in the range of 6 months, the median overall survival in the range of 1 year. With regards to safety though, when it came to patients who were heavily pretreated, especially the ones who were treated for 5 or more lines of treatment, the one toxicity that did end up being slightly higher than the other subgroups were cytopenias, whereas with regards to CAR T-related unique toxicities like cytokine release syndrome or neurotoxicity, there was no difference at all. Like I had alluded to, grade 3 and 4 cytokine release in 1%, and grade 3 or 4 neurological toxicity about 9%. There were absolutely no grade 5 related CRS or neurotoxicity seen in this cohort. So basically, I think as a conclusion, it is heartening to see that patients who had relapsed mantle cell lymphoma derived benefit from Lisocabtagene maraleucel despite prior lines of treatment. However, based on post-hoc subgroup analysis, we do see a slightly lower response rate in patients who have received 5 or more lines of treatment, as well as in patients who are refractory to a prior BTK inhibitor. Thus goes on to tell that I think Lisocabtagene probably needs to continue to be evaluated in earlier lines of treatment because the safety of liso-cel is exceptional. Patients really manage this very well. So at this point in time, I do believe it's an excellent choice for patients with relapsed refractory mantle cell lymphoma.